Okay, good morning, everyone. So first of all, I'd like to thank Rich for inviting me to talk about this. This trial has been going on for 8 years, and you're going to be the first to hear the results. This is the Tinnitus Retraining Therapy Trial. So as Rich has already said, tinnitus is a pretty common condition. Lots of people have it, and it's been estimated, this was a while ago, 2000, that about 15% of the US population, about 50 million people, have tinnitus. And some of those, many of those, as Rich showed us earlier, say it has no impact, it doesn't bother me. But there are some people for whom it's a real problem. They're just really severely impacted by the tinnitus, and about 2% of the US population have tinnitus as a real problem. And so those were the people that we were aiming to help in our trial. There have been a lot of different treatments for tinnitus, varying from, and they've either tried to treat, as Rich has said, either the tinnitus itself, the physiological mechanism, or the reactions to tinnitus, going from antidepressants, acupuncture. Cognitive behavioral therapy has been shown to have some modest effect on reactions. Masking, which obviously Rich will tell us a lot more about later, and transcranial magnetic stimulation is a new therapy which is thought to help with the actual tinnitus. But the effectiveness of many of these has not been shown. The last one on this list, tinnitus retraining therapy, was introduced by Jastroboff in the late 90s, and that's the topic of our trial. So tinnitus retraining therapy is aimed at reducing the reactions to tinnitus. It's a structured treatment protocol, and it uses the neurophysiological model developed by Jastroboff, which includes both the the input of the auditory function into the brain and the reactions of the person involving the limbic system and the fight or flight reactions. It uses two components. It uses a directive counseling, which initiates habituation. It allows people to learn to live with the tinnitus, to treat it like refrigerator noise so that it doesn't bother them. The other component is sound therapy, which facilitates habituation of the perception of the tinnitus. That is the awareness of the tinnitus. People suggested that we needed a trial of tinnitus retraining therapy, or TRT. Many people had had very small trials or small observational studies looking at TRT, and which suggested that it was an effective treatment. But a lot of these were not controlled, or they had other failings as methodologically. So that we could not really completely trust their results. In 2010, there was a Cochrane review on TRT. This was a study done by Jim Henry that compared TRT with masking and showed that TRT had a modest benefit over masking. But the problem with that trial is that there were a lot of problems with it. It had a high risk of bias, and so the results were needed to be taken with a grain of salt. So in this area of uncertainty of what we call equipoise, we didn't know whether TRT was really a good treatment or not. Craig Formby and I put together a funding application to the National Institute of Deafness and Other Communications Disorders, and we were funded to do the TRT in 2009. So the tinnitus retraining therapy trial is a randomized, placebo-controlled, multi-center trial. And our aim was to test the efficacy of TRT versus standard of care treatment in individuals who have self-perceived debilitating tinnitus and are seen in US military hospitals. So why did we choose to do this in the US military? Well, we were looking for what we call an enriched population, more people, where there's going to be a population of that has more people with tinnitus. Military personnel, as you might well guess, are exposed to a lot of noise, and a lot of loud noises and explosions and so on. The people who actually measure the prevalence of tinnitus in military personnel, the study Theodorov did a review and found that people said that anywhere from 6 to 76% of people coming from deployment in Iraq and Afghanistan wars came back with some form of tinnitus. The Veterans Administration did a report in 2014 showing that 1.2 million veterans have some kind of a service-related disability for tinnitus. So it's a population that has a lot of tinnitus. So our study hypothesis is that the TRT is an efficacious therapeutic intervention for severe disabling tinnitus, resulting in the habituation of the sensation, awareness, annoyance, and impact of tinnitus. And we also hypothesized that both components were necessary, both directive counseling and sound therapy were necessary components for the therapy. We had 3 treatment groups. Now, this was a randomized trial, and so what happens is people are randomly assigned to one group or another. And the 3 groups were the TRT group that received the full TRT treatment, directive counseling and sound therapy. We had a group that we called partial TRT. This group received the same directive counseling, but they received a placebo sound generator. And this sound generator was designed so that when it was put in the ear, it would emit the soft seashell-like noise that we used in our therapy. But after about 30 minutes, the noise would fade away. Participants, this has been tested in a couple of studies, and participants really do, because the noise is so low, participants do not realize that the noise is gone. And then the standard of care, which we developed, which we had to define the standard of care, and this was one of the big components. Importantly, everybody was told to increase their environmental sound. All 3 groups it was suggested that they also have sound in the environment. Looking at the difference then between what we developed for the standard of care, and Sue Erdman, who's going to talk later this morning, will tell you more about the standard of care, and Susan Gold will tell you more about the directive counseling, but I'm just going to give you a brief outline. The directive counseling, as I said before, is based on the neurophysiological model of Jastroboff. So it's theory-driven. It's pretty didactic. It's very much someone telling someone what to do, how to proceed. Directive, and it's really kind of top-down. In contrast, the standard of care is based on existing practices. We surveyed the clinics to find out what do you usually do in treating tinnitus patients. And so we took all of that together, and anything that was done frequently in a clinic was included in our standard of care. We also included the ASHA guidelines, which were fairly succinct, but we tried to address them, and so the standard of care was a combination. So in many ways it was best practices at the time. It was patient-driven. It was more interactive, more facilitative. It was talking to the patient, sort of what Rich was saying in terms of talking to the patient, finding out what are the problems. And it was horizontal. The counselor was someone who was working with the patient, trying to help them. So these were the 2 counseling, the 2 different types of counseling. How did we make sure that the counseling was done properly? So for the directive counseling, we had a script. Susan Gold spent a lot of time developing a script and writing down everything that's in her head to show. We had handouts that we would give to the study participants. We used 3D ear models. Same thing for the standard of care. We had a script. A little tough to write a script for something which is very ongoing and very patient, very individualized, but Sue managed to do it, and she'll tell you more about that later. Also used a 3D model. for the directive counseling, because part of the counseling involved pictures and to explain the brain pathways, to look at the picture of a cochlea and the hair cells. We had a flip chart that was designed for the counselor to show the picture on one side and the talking points on the side that faced the counselor. And then in both cases, we audio taped with a voice recorder the counseling sessions, which we then monitored for quality purposes in order to make sure that the treatment was adhered to. As I said before, Craig is the study chair, the person behind this in many ways. I directed the coordinating center, and our current project officer is Stephen Hirschfeld. But I do want to say a real thank you to the person who was with us until 2015, Gordon Hughes, who was our project officer to then. I think some of the rest of you may have had interacted with Gordon, and he was just a really great project officer, very encouraging. Our clinical sites, the Air Force. We had two Air Force sites, Wilford Hall Ambulatory Surgical Center in San Antonio, Texas, and David Grant Medical Center, which is in Northern California. The Army and Navy together were represented by Walter Reed in Bethesda. And then we had 3 Navy sites, the Naval Hospitals in Portsmouth, Virginia, San Diego, California, and in Camp Pendleton. So altogether we had 6 sites. Our eligibility criteria, who was in the study, what was our study population? They had to be active or retired military personnel or dependents. And this translated into having what is called the TRICARE insurance. They needed to be able to be seen in a military hospital. Adults 18 or older, but we had no upper age limit. They needed to be able to understand and complete English language questionnaires and understand the counseling, which was done in English language. And they had to be obviously willing and able to participate in a research study. For the medical criteria, we required that the tinnitus had to be present for at least a year. It had to be chronic, it had to be continuous over that period of year. And it had to have no known medical reason for the tinnitus. So it was subjective tinnitus, no known etiology. We wanted to make sure that these people were suffering from the tinnitus. And so one of the questionnaires we used as a screening was the tinnitus questionnaire. This is a 52-item questionnaire, and people needed to score 40 or more, which is a level of at least moderate tinnitus. But people who said that tinnitus was a real problem. And they needed to not use hearing aids, so these were functionally normal hearing people. Hearing sensitivity bilaterally within the audiometric range from normal to mild. Our outcome, our primary outcome, the way we were going to say whether this trial, whether the TRT was effective or not, we used the change in the TQ score, the tinnitus questionnaire score. And this was evaluated longitudinally between the baseline visit and the 18-month visit. What that means is we did it's like a repeated measures. And so we used all the measures. We used the value of the TQ at every follow-up visit for each person and included all of that data together in a model, in a statistical model that we used to look at the data. Our secondary outcomes, evaluated the same way, were all of the subscales in the TQ. The TQ included many of the subscales that Rich mentioned, areas of sleep, concentration, emotional difficulty, auditory difficulty, somatic difficulties. We also looked at the tinnitus functional index and the subscales within it, and the tinnitus handicapped inventory and the subscales within it. We used the visual analog scales of the TRT interview, which included things like measuring the ranking of the problem, the impact of the tinnitus, the annoyance and the loudness of the tinnitus, the perception of the person on the tinnitus. We included another measure, the digit symbol substitution test. This is a test that's usually used to measure cognitive impairment. But it was also, because it's a timed test and because it's used, short-term memory, we used it as a measure, we thought we could use it as a measure of concentration. I won't present any data on that today, but we're going to be investigating whether this is, a different way of measuring one of the aspects of tinnitus that are really difficult for people who have really difficult tinnitus. We measured the EuroQoL, which is a general health-related quality of life index, just to see whether the quality of life was impacted by the tinnitus separately. And then we did the audiometric measures that, that Rich has mentioned, the tinnitus pitch and match and loudness discomfort levels. Study visits were the baseline eligibility visit. Randomization could be at the same time or at a separate visit. There were 2 treatment visits. The first counseling session, we aimed to conclude within 1 month of randomization, although because it was military and people were deployed and had TDY and all these other things, sometimes it was a little bit longer. But so all of the follow-up visits were then tied to the treatment visit rather than the date of randomization. This follow-up treatment visit was 1 month after the first treatment visit, and then other visits were at 3, 6, 12, and 18 months. We enrolled 151 study participants, 49 to the standard of care, 51 to the partial TRT group, and 51 to the TRT group. This was over a period of about 4 years to enroll this number of people. Okay, our study population. These are the demographic characteristics. Across all groups, the mean age was about 50, plus or minus 10 years. So this was really a middle-aged population. About 70% were male, which is about the proportion of men to women in the military. In terms of the race ethnicity, about 75% were white. About 10 to 12% were Black or African American, and the remainder were other races. We had Asian, we had a Pacific Islander, so all of the different categories. If you've ever been involved in an NIH study, you have to list these. We had about 10% Hispanic. And importantly, you can see across the groups that the proportions were fairly similar. So that just tells me that randomization worked like it was supposed to. About 80% of the population were married, and the remaining people did not have a partner. Either they were widowed, or they were single, or they never married, or they were divorced. This is their baseline audiograms. These are box plots. The standard of care is black, partial TRT red, and TRT is white. And the box plots show the interquartile range. That is the 25th to the 75th percentile of the population. You probably can't see it, but the little line in the middle is the median. And so, again, these are pretty typical of an audiogram for this population. Okay. And it also shows that we did have people who had basically functionally normal hearing. So their tinnitus. The tinnitus in most people had been a problem for quite a while. We had the criterion that it needed to have tinnitus for at least a year, but most of these people had tinnitus for at least 2 years, and almost half of them had been suffering with tinnitus for over 5 years. So this had been a problem for a long time in the study population. The majority of people said that the tinnitus had a gradual onset. although some people, and the remainder, said that it was a sudden onset, or some people just didn't know, couldn't respond. And about half the people said that there was some event that was associated with the onset, which we would have expected in our population because of the noise exposure. Almost everyone said that the tinnitus was tonal, that is some tone that they could identify. And a few people said it was a low frequency noise, and one person said it was a high frequency, and one person said it sounded like crickets. So again, sort of what you would expect. And again, fairly even distribution across the 3 study groups. In terms of location, between 10 to 20% said it was in one ear. So about 40% said it was in both ears. About 20% said it was in the head, and the remainder said it was in the head or in one or both ears. So fairly, so this is not quite the 50% bilateral distribution that you showed earlier, Rich, but I think it's close. So their most troublesome tinnitus, so I'm just showing you the results for the left ear here, but the right ear was similar. The loudness match in decibels was 38, 40, 46, so around 40 decibels, which is the median. And the frequency match was 6 to 8 kilohertz. Okay. Loudness discomfort levels that we measured, again, using the same colors to show the different groups, was between 95 and 100 for the median. There probably were a fair number of dots above there. The dots mean these are outliers. These are above the 95th percentile. And so there were some people, so these people in this area would be those that we would consider to have hyperacusis. In terms of the baseline tinnitus distress, this is their reaction. How did they score at baseline on the tinnitus? The median score on the tinnitus questionnaire was in the 50s, as was the mean. So this was a moderate level. Remember, we had a baseline of 40. The tinnitus functional index. The median baseline value also was in the 50s, maybe a little lower in the TRT group. Tinnitus handicapped inventory, about 38 across all groups, and the measure on the VAS scale from the tinnitus TRT interview on the ranking of the problem was about a 6 to 7. This is on a scale of 0 to 10. So these were people who basically had a problem with their tinnitus, who were having some reaction to the tinnitus. Okay, so here is our outcome data. These are the TQ scores by visit and treatment group. Again, the standard of care is the black circles, the partial TRT is the red squares, and the TRT are the blue triangles. And as you remember, the visits were at 3, 6, 12, and 18 months. This is everybody together. And you can see that there was an increase, an improvement based on the TQ score at 3 months, continued improvement at 6 months, which then leveled out at 12 and 18 months. We also looked at change because people had different baseline values, and so we wanted to make sure that we wanted to see what was the change for an individual, and so that was this score. And so we can look again. Again, there was the same pattern. It was still an increase at 3 months, 3 months to 6 months, which then leveled out across time. But all the groups are fairly similar. These are means and standard errors, and so the groups all look similar. We did look to see whether each group improved. So this is looking at the change, just not looking longitudinally, but just simply looking at the change between baseline and 18 months in the TQ in the 3 different groups. And you can see that the change in the TQ score, -16, -19, -18, the 95% confidence intervals do not cross 0, and so these are significant. The P might grade less than 0.001 in all groups, so all groups improved. Of course, the question is, did any one group improve more than the other? And so this is our model. It's a GE, a generalized estimating equation model, for those of you who are statistical buffs. And in this model, we adjusted for age, for baseline TQ as a continuous variable, for the visit, the clinical center, and gender. We did look at audiologists because we thought there could be some audiologist interaction, and we also looked at the type of sound generator. We started out with behind the ears and ended up with in-the-ear devices, so we wanted to see if that was going to have an effect. They did not. But our estimate shows that compared with the standard of care, partial TRT only changed -4 points, so it was only 4 points better, but the confidence interval crosses 0, crossed 1, so this is not significant. Same thing with TRT. So what this tells us is that there is no significant difference between the treatment groups, and they all improved. The other way to look at this would be to look at the proportion of participants by how many improved clinically. I mean, that's also an important thing. So there are 3 groups of 4 here: the standard of care, the partial TRT, and the TRT reading across. And this is at the months of follow-up. So the numbers underneath, the 3, 6, 12, and 18 months. The definition of clinically significant improvement in the TQ is a change of 10 points or more. And so someone who is considered better has a decrease of 10 points or more, and those are the blue in the bars. You can see a significant, about 70% of people showed a clinically significant improvement based on a change of 10 points or more. Some people had no change, so they stayed within either plus or minus 10 points, and a few people, the white part of the bars, actually got worse, so did not help. This is the same graph, only looking at the tinnitus functional index, and generally we see the same pattern, maybe a little bit bouncier. But it's still showing an improvement from baseline down to 12 months and then a straightening. And this is the tinnitus handicapped inventory scores by visit and treatment group, again showing the same pattern. This is the change in the perception of the patients in the ranking of their tinnitus problem. Using the TRT interview VAS scale, and showing that they all thought their tinnitus was getting better, that it wasn't as much of a problem by about 2 points. And it's just as an aside, it's not often you see the lines line up so closely. So conclusions. All 3 treatment groups, TRT, partial TRT, and standard of care, showed improvement as measured by a significant decrease in the TQ score from baseline to 18 months. And I think that's really important. There was no difference between the treatment groups in the change in TQ measured longitudinally. So all the groups improved, and there was no difference between groups. And we saw the same pattern of improvement across the other measures, the TFI, the THI, and the VAS. I'd like to acknowledge NIH, NIDCD for supporting us, Craig and myself. Special thanks to the study participants who enrolled. Thanks to General Hearing for their assistance in developing the sound therapy devices. And just to say hello to the Roman empires, Augustus, Claudius, Aurelius, and Tinnitus.